So my name is Mike Farquhar. It's my third time doing this, which is slightly random for an ENT talk to come back and talk to you 3 times. So I'm a consultant in sleep medicine, as Aishan said, at Evelina, London. So I have come and spoke about paediatric ENT sleep stuff here before. I spoke about LGBT stuff last time. This time I'm talking about something which is, I guess, my other kind of main extracurricular activity professionally, which is talking about the impact of fatigue and sleep deprivation, particularly in the context of shift working. So this is not ENT specific, but I think this is something that we need to be much more aware of within the NHS as a whole. I think one of the things that the last year has emphasised is that thinking about these kind of human factor elements in the service that we deliver is really important. And I think we're going to really have to get this right going forward in terms of how we provide services in the NHS. As before, I witter away about all sorts of things on social media, and if you want to talk or chat to me, then there's Q&A at the end, but you can also find me on Twitter, and there's usually links to information about things that I talk about a lot on Twitter as well. The context of this, I became a consultant at Evelina, London, coming up for 8.5 years ago. And when I started work as a consultant, one of the things I went to our medical director and said was that I really wanted to start doing some education work for our staff about the importance of sleep for them. And that was something that when I went to our medical director then, so that was beginning of 2013, she kind of said, yeah, very interesting, but induction is already packed full of stuff and we really need to teach them how to wash their hands and use a fire extinguisher and all the rest of it for the 10th time. There isn't any time to do this kind of teaching in induction. That is something that's changed, and over the last few years, we've begun to see a change in the way that the health service thinks about this type of education and teaching. So where, 8 years ago, me rocking up saying, I want to talk about two doctors about sleep and working night shifts, which is what the original focus of a lot of this was about, was seen as controversial and a bit left field. We are starting to see a lot more of these conversations happen. And although the BMJ has its pros and cons, what makes it to the front cover of the BMJ is quite a good temperature check of what the profession is thinking and talking about. So we start to see stories like this pop up on the front of the BMJ saying we need to think about how you manage sleep in the context of working shifts. I'm a sleep doctor, and a lot of what I'm going to talk about comes filtered through that kind of perspective of sleep and sleep medicine. And as soon as people like me kind of pop my head above the parapet and start saying to people like you, I think you should think better about your sleep, and here are all the reasons why, as this BMJ editorial kind of demonstrates, what often then immediately comes back is that you will say things to me like, well, actually, that's well and good. I know that sleep is important. I understand all of that. But actually, it's really difficult for me to prioritize sleep in my life because modern life is stressful. It's very anxious. I work a job that makes me shift around the clock and has lots of demands. And I'm trying to do everything. And actually, just following this kind of basic advice is really difficult. And that's one of the big challenges about sleep medicine, is that actually when we're talking about why people are vulnerable and what we can do to help, a lot of it is about trying to help people to do the simple things really well, even when working in the type of jobs that you do and working in the kind of conditions that we do in the NHS. That is very much exemplified by the fact that that idea that the core of sleep medicine is about doing simple things well is that whilst this is an editorial comment from the BMJ, and whilst everything it says is absolutely true, it was originally written in 1895. And although the language is slightly different, you can kind of tell when you read it with that in mind that it was written a little while ago. A lot of what it says is still exactly the same. So in 1895, they thought they were just as modern, the pinnacle of human civilization, as we think we are. And they had all the same excuses and reasons for why prioritizing sleep was difficult. So one of the real challenges of any sleep physician is that trying to persuade people to think about sleep and to think differently about sleep is a challenge that has been around far longer than I am. 1895, by the way, feels like a long time ago. Before the pandemic, if I got my commute to work wrong, it looked a bit like this on the tube in the morning. It was all crammed and horrible and rubbish. That makes me feel slightly sick looking at that now. We've got so used to not being like that. But actually, you dial back to 1895 when that editorial was written, and although the crowd is different, it's all kind of middle-aged white men in bowler hats compared to the slightly more diverse crowd that we'll see in London these days, the experience is very similar, that morning commute. We spend a lot of time telling people today that modern life has ruined conversations and you're all spending time on your phones and not talking to each other and all the rest of it on things like public transport, buses and trains. And of course, you dial the time back a little bit and the technology is different, but the people aren't. And again, that kind of idea that when we're talking about something as fundamental as sleep, these kind of basic principles relate to how we are as humans, not necessarily to whether we're in the 19th century or the 21st century, is really important. So with that in mind, why or how did I persuade my medical director that this was something that we should be talking more about? There are lots of reasons, and we'll touch on some of those over the course of this talk. But the reason I wanted to do work around this when I started as a consultant, and the reason that persuaded my medical director, is because of stories like these. These are doctors and nurses who have crashed and died just driving home after a night shift. When we ask people to work around the clock in particular, when we ask people to function at nighttime as if they're awake, and they become sleep deprived and fatigued as a consequence, one of the most devastating, or the most devastating consequence of that is that you are significantly increased risk of road traffic accidents, of dying just because of the way that you are working. I think there's probably a story like this about once every 6 months. They hit the local newspapers, they never hit the national newspapers. But these are the human cost of just providing a service that functions around the clock. And although I don't think we can reduce the risk of this to zero, I think there is a lot that we can and should be doing to be more aware of these risks and how we can mitigate this as much as we possibly can. Ronak Patel in the bottom right was a junior anaesthetist who crashed and died driving home after a short run of nights. And in response to his death, the anaesthetic colleges, the Royal College, the Association of Anaesthetists, took that very seriously. And actually, they've been doing a lot of work since his death a few years ago to think about how they, as a specialty, can support their juniors in particular. It's now expanding to everybody within their specialty better when we're thinking about the impact of fatigue. And as part of that, they did a survey of all of the anaesthetic doctors in training a few years ago, trying to pick out all of the ways that fatigue impacts on them. And from that, we took some of the headline kind of things to get this a bit of public impact. And this kind of idea that if you speak to people who work night shifts regularly and say, do you ever feel unsafe driving home? Have you ever had a near miss driving home? About 50% will report having had a near miss where they could have had a devastating outcome. And about 90% will say that they feel unsafe if they have to drive home after a night shift. That survey, by the way, the link is there, is a really good summary of the impact of fatigue on every aspect of their personal and professional lives as anaesthetists, as a really good way to kind of highlight the impact that fatigue can have on us. Anaesthetists, though, are an interesting specialty within medicine. This is data from the GMC survey that doctors in training and their trainers complete every year. And this question is asking about intensity of workload. So the bits at the bottom, the orange and the blue, are the proportion of people in each specialty that rate the intensity of their workload as being high or very high. Anaesthetics is the bar at the left, and you will see that compared to most specialties, anaesthetists do not really rate the intensity of their workload that high. So we can be pretty sure that if anaesthetists are telling us that this is a problem, I don't need to go and survey every trainee in every specialty to be able to say that this is a problem that is probably consistent across the whole of the NHS. So what we are looking at is an issue, so fatigue, that is endemic to the way that we work, has a huge range of consequences and costs. And at the most extreme, this is something which results in fatalities of people who are just trying to do their job and provide a service. So it is absolutely something that I think we should be doing something more about. The question then becomes, what do we do about it? And when we're thinking about this, I tend to split it into things that individuals can do to be more aware of fatigue and to manage that, and then systemic things. And we need both things. Actually, more of the emphasis needs to be on the systemic changes. But the teaching that I did to begin with around this was focused on supporting individuals. So I'll cover that bit first. So what this is about is, what can you do as individuals to try and manage the consequences of sleep deprivation and fatigue on your ability to function and work? That comes down, first of all, to that kind of idea that I kind of alluded to at the beginning, which is that if I was able to ask you and get you to stick your hands up or whatever, do you get enough sleep? I can be pretty confident that most of you probably will self-report that you are not getting the right amount of sleep already. And that's before we start thinking about you working around the clock. And the reason I can be pretty confident of that is that we've got good data from the UK and from other similar countries that tells us that most adults actually do not get the right amount of sleep most nights of their lives. So as adults, you should be getting probably around about 7 to 8 hours of sleep most nights. We know that most adults are probably getting about 6 to 7 hours of sleep on average every night. And when you say it like that, it doesn't really sound very much. You know, you're meant to get 8 hours, you're getting 7, you're meant to get 7, you're getting 6. What's the big deal? But if you think about that in a slightly different way, if you're missing an hour of sleep every night of your life, what that means is you are missing the equivalent of an entire night's sleep every week of your life. And although I'll touch on in a second on some of the reasons why sleep is important to us, you are just going to have to trust me that sleep is the absolute foundation of your physical and mental health. And if you are missing the equivalent of an entire night's sleep every week of your life, that is going to have a consequence. And if we are then going to plug you into rotas that has you working around the clock and being asked to provide urgent and emergency care at 3 o'clock in the morning, then that means that is going to have an impact on your ability to do that safely and successfully. So you are probably sleep deprived already. And that is one of the main areas of focus when I'm looking at the individual things that people can do. How can we help you to sleep better every night of your life if sleep deprivation is something that you are going to have to deal with professionally? Why is sleep important? So I can literally talk about this for all day. We often get the kind of idea from this cartoon at the top that nobody really knows what sleep is about. We all spend a third of our lives asleep and no one understands what it's for. That might have been true 50, 100 years ago, but actually we do have a much more nuanced understanding of what sleep is for compared to what we did 50, 100 years ago, even 10 years ago. One of the things I love about sleep as a specialty is that actually we're constantly finding new things and new evidence and unpeeling new benefits or new reasons why sleep is so important to us. However, the best way to think about sleep is to simplify it down to this. If you have a complex bit of machinery like a car will need regular maintenance, regular repair work to keep functioning at its best. If you skip the maintenance, the car will carry on functioning for a while, but the longer you skip the maintenance, the more likely problems are to develop, and the more likely those problems are to be significant. And if you're a car owner, it probably means you're going to end up spending more money overall to get the problem fixed than if you've just done the maintenance in the first place. Your brain and body are a complex piece of biological machinery. And just like a car, they also need regular repair and regular maintenance to keep them functioning at their best. And this is a big part of what sleep is doing for you every night of your life. It's that regular maintenance, the equivalent of a nightly MOT check that makes sure every aspect of your brain and body is functioning as it should be. And when you do not get the right amount of sleep, we quite rapidly begin to see the consequences of that beginning to accrue. I can take any body system, any health function, and give you an example of how sleep affects it. But one that I think is particularly relevant for healthcare, and particularly over the last year, is that the functioning of your immune system very much depends on you getting the right amount of sleep on a regular basis. If you get the vaccine for a common viral infection, such as the flu, we've got data that tells us if you are sleep deprived when you get the flu vaccination, it will take significantly longer for you to get to protective levels of antibodies than if you get the vaccination when you are not sleep deprived. There is data that tells us that if you are sleep deprived and you were exposed to a respiratory virus, such as flu or the common cold coronavirus in olden days, you are 2 to 3 times more likely to become symptomatic than if you have had the right amount of sleep. So something as fundamental as our immune system depends on a good functioning or an appropriate amount of sleep. And we spend quite a lot of time in the NHS making sure that people get their flu vaccinations. I don't think we spend very much time making sure that they haven't had a bad night's sleep or they're not chronically sleep deprived before we do. But that kind of emphasizes the importance of sleep. So that's the immune system as one example, but there are countless examples across any system. When we look at that from a personal and public health perspective, one of the things that we are able to demonstrate is that when you are chronically sleep deprived, then that begins to have an effect on your overall health and well-being over your lifespan. So when we look at this from a public health perspective, when the population is chronically sleep deprived, we can tally that to increased risks of incidence of cardiovascular disease, so heart attacks, high blood pressure, strokes, to some types of cancer, to type 2 diabetes, to obesity, to mental health problems such as anxiety and depression, to neurological diseases such as Alzheimer's disease. Your risk of developing any and all of these diseases goes up when your body is not getting that regular repair and maintenance. If you are chronically sleep deprived, your risk of developing these problems over your lifetime goes up. And at a public health level, that effect is very significant. So there's a lot of emphasis these days on trying to think about how we optimize things like sleep to reduce the public cost of diseases like this over the long term. So that kind of cost on every level is really important when we're thinking about the impact of sleep on health or sleep deprivation on health. There are a few more specific individual impacts of sleep deprivation, though, and some of these are very relevant when we are then thinking about why you are more vulnerable to things like road traffic accidents. Again, I would normally ask you, if I was doing this in person, to stick up your hands if you drive. And what I would then get you to do would be to stick your hands down if you would not drive if you'd had a pint of beer or 2 glasses of wine, or to keep your hands up if you'd be happy to drive if you'd had a pint of beer, 2 glasses of wine. And what I generally find is most people put their hands down. These days, we've kind of socially conditioned everybody to understand that even a small amount of alcohol is going to significantly affect your risk of having a road traffic accident, so that most people these days will not be comfortable driving if they've had really any alcohol at all. That is a huge social change. So when I was growing up in the Highlands of Scotland in the 80s and 90s, the attitude towards drink driving was very much this, that if you were not paralytically drunk, then it was probably still okay to get behind the wheel of a car and try and safely inch your way home. Whereas these days, what we have is very much a zero tolerance attitude to drink driving. So if you've had any alcohol, you don't drink. And the reason for that is because even a small amount of alcohol will impair your reaction time such that your risk of a significant road traffic accident goes up. What we are less good about thinking about are the other factors that have a similar effect on functions such as reaction time. And actually, again, we have good data that tells us that if you are sleep deprived, that will also affect your reaction time to the equivalent degree. If you have been functionally awake for 16 to 18 hours on average, your reaction time will be impaired to the same degree as if you're at the legal drink drive limit. And that 16 to 18 hour figure assumes that you are not already chronically sleep deprived, in which case you'll get there quicker. It also assumes that you've not just been working a run of nights where you've been sleeping less well in the daytime, less good quality sleep, and less sleep overall. So we get to that point quicker when we are sleep deprived. I am willing to bet that those of you who would probably have hesitated to get behind the wheel of a car if you'd had a pint of beer, 2 glasses of wine, would not hesitate in the same way about getting behind the wheel of a car if you'd been awake for 16 hours, because we don't think about this in the same way. But the impact is the same. Your reaction time is impaired to the same degree. You are just as vulnerable, if not more so, because for 2 reasons. One, because the impact of fatigue tends to accumulate exponentially more quickly than alcohol does, but also because you don't appreciate the risk that you are at when you are tired and drive. So we're less aware of the risk than we would be for something like alcohol. What that all boils down to is a really simple point, which is driving tired is like driving drunk. And when I'm trying to persuade people to change policies in hospitals and how we work about these things, I tend to boil things down to really simple points, partly because it makes it easy to understand, but more importantly, because it's then really difficult to refute it. And if you can't refute it, you're going to have to do something about it. So when we are thinking about our staff finishing night shifts, we need to be taking on board the fact that by that point, they are probably already tired enough that if they get behind the wheel of a car, that is the same as them getting behind the wheel of a car if they were at the drink drive limit. And that means we have to think better about how we do these kind of things. As part of the work we've done around this, we did a short documentary with the BBC a few years back. And as part of that, we stuck a junior doctor in a driving simulator at the end of her normal night shift. And she made it home, she didn't crash, didn't die. But when they went back and analysed it, the number of near misses that she had that she wasn't even aware of due to the impact of fatigue was really quite scary. So if you want to look at that, the link to that is there. It's only 10 minutes, the whole thing, but it's a really nice way to illustrate just how vulnerable people are just getting in their car and driving home after a night shift. There are other simple points that then also apply. You hopefully still remember when we were able to travel around the world far enough to get jet lagged. And most of you, I'm sure, will have had the experience of being jet lagged at some point or another. And it's not a pleasant experience. When you're jet lagged, you feel awake when you want to be asleep. You feel sleepy when you want to be awake. You get physical symptoms, so aches and pains and upset stomachs. You get headaches. You find it more difficult to think things through. You might be a bit more short-tempered and irritable. Jet lag is not a pleasant state of affairs. The reason we get jet lagged is because one of the most powerful drives you have in your body is what we call your circadian drive, your body clock. which very roughly is trying to keep you awake in the daytime and asleep at nighttime. It's a little bit more complicated than that. And there are two key concepts to think about when we're thinking about circadian drive. So along the top of this diagram, there is the arrows representing what we call sleep pressure or sleep load. And this is basically the idea that the longer you have been awake, the more you need to sleep. And sleep pressure builds up fairly linearly through the day. So the longer you have been awake, the higher your need for sleep is. However, most of us do not get progressively more tired as we go through the day. Most of us maintain a fairly even keel of alertfulness throughout the day, and it's only towards the end of the day that most of us start to feel tired. And that's because the other element of this, the body clock element, is what we call the circadian alerting signal. So this is the way to think about this, is a signal that's coming from your brain that's keeping you awake. It's like a constant stimulus, a prod to keep you awake and functioning. And it's counteracting that sleep pressure that builds up through the day. At the beginning of the day, when your sleep pressure is low, your circadian alerting signal doesn't really need to be very strong to keep you awake. So we have a relatively low alerting signal at the beginning of the day. But as the day goes on and the sleep pressure rises, the alerting signal will rise to match that. It doesn't rise completely evenly though. And one of the quirks of our body clock physiology is that our alerting signal doesn't increase quite as quickly as the sleep pressure accumulates around about the middle of the day, the early afternoon. And that's one of the reasons why we all tend to get that post-lunch lull, where we all feel a bit more sleepy after lunch, where in other more civilized cultures, they pop off for a siesta in the early afternoon. What most people then find is that as the day goes on, even if they felt more sleepy post-lunch, they tend to feel more alert later on. And that's because the alerting signal then really ramps up. So not only does it then rise to match the sleep pressure, but actually it goes into overdrive. So at the end of the day, around about this time, in fact, the alerting signal is sending a really, really strong signal to keep you awake. It's only then as we get a little bit further into the evening, as the alerting signal then starts to drop off, that the sleep pressure is unopposed, and that's what then helps us to get to sleep at our normal bedtimes. Sleep pressure is then dissipated by deep sleep. So those of you who've heard me talk before will have heard me talk about different types of sleep and how that relates to different patterns of sleep disorder breathing. Deep sleep, which we tend to get at the beginning of the night, gets rid of the sleep pressure. The sleep pressure drops off quite quickly, but we stay asleep in part to a number of things, but in part because the circadian signal stays quite low. So there isn't that prod to wake us up until the next morning comes along and the alerting signal kicks in. Understanding these interactions is one of the things that we look at when we're looking at people with sleep difficulties. And you can already start to see that once we start thinking about people working around the clock, this begins to be relevant. So if you come to do a night shift, you've not slept, your sleep pressure is going to be high. When you get to 3 o'clock in the morning, your alerting signal is going to be virtually zero. Your sleep pressure is going to be high if you've not slept, and you are going to feel absolutely rubbish. So understanding these interactions helps us to understand the changing pattern of alertfulness that people get, both through the day, but also the changing patterns that we see when people work at night. The more basic point about all of this, though, is that at 3 o'clock in the morning, every cell in your brain and body is telling you that you are meant to be asleep. And when we ask you to work a night shift, we are expecting you to function as if you were awake. That is physiologically the same thing as asking you to work as if you have just got off a plane from Sydney and you are jet lagged. And we wouldn't really expect people to do that. And again, that's a really basic, simple way of getting this point across. Working at night is biologically unnatural. It is not what we are evolved to do. But when we ask people to do that, we are asking them to try and function at their best when their body is telling them to be asleep. And once you put it in these kind of terms, then chief execs and chairs and heads of departments and all the rest of it get that concept. Working at night is not a natural state of affairs. That mismatch between circadian biology and what we're asking you to do means that shift workers are then at increased risk of all the consequences. And you don't need to read the small print on this. This is a BMJ review talking about the health consequences to shift workers of getting insufficient sleep. And all those risks I talked about earlier for people who are chronically sleep deprived in terms of their health, all of those things are not only true, but even more so for shift workers. Shift work fundamentally is bad for you. I was reading a review published this morning in Thorax, which has shown that one of the things that, or one of the factors that makes people more likely to be admitted to hospital if they have COVID is if they're a shift worker. Because again, it is increasing your vulnerability from a health perspective. When we ask people to work shifts at night, we are asking them to do something that fundamentally is bad for their health. And that is also something I think we should be taking a responsibility as employers about, to mitigate as much as possible. It also has a consequence for patients. When we look at other cognitive functions, so this is an experiment looking at risk assessment of junior doctors in an intensive care environment in Southampton. When you ask junior doctors to make decisions about assessing risk, and you do that when they are at the beginning of a night shift and at the end of a night shift, so at different levels of fatigue, they make riskier decisions when they are tired. And that probably doesn't surprise you desperately much. You will all, I'm sure, be familiar with the kind of end of night shift impulse buys when you nip off to the shops and suddenly buy things that you wouldn't buy normally, because our way that we assess things is different when we are tired. What doesn't change, though, is your level of confidence. If you are assessing a situation when you are fatigued, you will generally make a riskier assessment than if you were not fatigued, but you will be just as confident making the riskier decision than you would be making the safer decision when you are not fatigued. And from a patient safety perspective, what that means is that you will confidently be making decisions that potentially are placing patients at more risk. And that obviously has a huge consequence in terms of the care that we're delivering to our patients. We can look, by the way, at any aspect of cognitive functioning, and sleep deprivation will affect it. So reaction time, risk assessment, that ability to understand that your functioning is impaired is in itself impaired. So our cognitive function is not as it should be when we are fatigued and sleep deprived. That means the GMC have started to take an interest in this in terms of patient safety and looking at junior doctors' sleep deprivation as something which poses a risk to patients. They've had a few missteps along the way with that, but they are beginning to take that on board. And actually, once you start to do that, you quite quickly begin to realize that although a lot of the initial work I did about this was thinking specifically about night shifts, but actually once you start asking doctors about fatigue and sleep deprivation, it quite quickly becomes apparent that fatigue is something which is affecting many of us all round the clock. And we know, again, this is data from the GMC survey that tells us that doctors at all grades and all specialties, about a fifth of doctors say that they regularly feel tired in the daytime to the extent that it affects their ability to do their job. So fatigue is one of these hidden problems that has been there for a long time and is endemic in the way that we work, but it's not just a night problem. It's something that actually is impacting us all around the clock. And that has a consequence for patients, because the more tired you are, the more likely you are to make a mistake. And when you make a mistake, that has a consequence for the care that we're delivering to patients. Other professions, by the way, are well aware of this. So the Health and Safety Executive publishes lots of stuff about fatigue and the impact on that. And there's lots of data from lots of different professions that tells us that if you are working more than 8 hours, your risk of having an accident or making a mistake at work goes up significantly. Of particular relevance from an NHS perspective, however, is that if you carry on working beyond 8 hours, so if you work 12 hours, by the time you get to working for 12 hours, your risk of an accident doubles compared to what it was at 8 hours. And because so many of our shifts are still 12 to 13 hours, this is something that I think we need to be very much mindful of, that when we ask people to work long shifts in particular, there is an inherent risk bound up in that in terms of how this impacts our ability to function. Athletes spend quite a lot of time looking at the concepts that this graph represents. So this is the performance curve. So this is kind of stress and pressure along the bottom and performance along the top. And if you look or talk to professional athletes, what they will tell you when they're training is they do not train 100% of the time. They train and then they stop and relax. They train and then they stop and relax. And the reason they do that is they know that if they just train constantly, actually their performance not only doesn't continue to improve, it starts to drop off. So they spend quite a lot of time trying to circle the top of this graph and keeping their performance functioning at its absolute best. All of the data tells us that when we overstress people, no matter what we're looking at, whether it's athletic performance or ability to do your job, when you overstress people, performance is not able to be sustained. We all have a kind of optimal level of performance, but staying at that level is something that we have to work at. And if you just keep piling on the pressure, the performance does not carry on along the dotted line, which is often the impression that we give people in the NHS, that we just expect them to continue functioning at their optimal level, no matter how much pressure they're under. All of the data tells us that performance drops off. And that's true when we model it across an individual working a single shift. It's true if we model it across a career. And if you always function under these kind of circumstances, then that increases your risk of developing other health problems. burnout, stress, of having to take time off work when you are not being able to function at your best. So thinking about modulating the stress and pressure that we're under is really important when we're thinking about the impact of things like fatigue on the way that we work. So for all of those reasons, we kind of said, or I kind of said, along with many others several years ago, that this is something we thought we should be stopping and thinking about better. And the question then becomes, well, if all of this is true, and this is a big problem, what can we do to try and make this better? It's a huge problem, and there isn't a quick and easy fix. It's not a new thing. So there have been published things over the years from a variety of groups looking at the impact of fatigue on different elements of the NHS and the health service in general. But the problem is a lot of these things were published and nobody then ever did anything with them. They were kind of top level publications that didn't translate into meaningful change on the ground. So when we started trying to tackle this, rather than trying to do it from the top down to begin with, we did it the other way around. And what we did when I started doing this work was working with junior doctors coming through our hospital to say, what can you do as individuals that helps you to cope better with the fact that we are asking you to do something when we ask you to work around the clock that is fundamentally unnatural. To do that, to begin with, we focus on their core sleep. So trying to think about the things that they can do to improve the quality and quantity of sleep that they are getting all of the time. And that's, again, about getting the basics right. So it's about thinking about how you optimize your environment, your bedroom, for good quality sleep, which is important for nighttime sleep, but it's even more important if you're a shift worker who has to sleep in the daytime. So what strategies are there to try and help you to get your bedroom as good as possible for sleep? We look at things like how to work through the night shift. So the cartoon is giving some examples of why caffeine is not the solution to every fatigue problem. So how to use things like caffeine effectively. And there's lots of hints and tips and strategies you can give people about how to work more effectively, particularly at night. Key things, and we'll come back to this. So regular breaks, absolutely essential. We'll come back to that. And one of the other things that's often helpful for many people working night shift is to be able to take short sleep opportunities, so power naps during the night, to help modulate the impact of fatigue on how they are working. We speak to them about getting home safely and how to assess that and decide what your risk is of getting home safely, particularly if you're using transport such as cars or bikes. And there are simple hacks around this. If you come out of a night shift into a bright sunny day, the light will tell your brain that you're meant to be awake, which means your ability to get good quality sleep is going to be further impaired. So simple hacks like sticking on sunglasses can help to make a difference. And there's lots of little things like that that can modulate people's experience of sleeping around the clock when we're thinking about it in the context of shift work. And then we talk to them about how to recover their sleep at the end. So if you've just done a run of nights and you finish on a Monday morning, a lot of rotas will then expect you back at work to do a day shift again on the Wednesday. So you then have a very short period of time to reboot your sleep. So we talk to them about how to reset and reboot their sleep at the end of night shifts to try and bring them back. That teaching takes about an hour. We've been doing it for a long time now. And when we look at the experience of trainees who've had that and say, look, was this any use to you or not? About 3/4 come back and say, yep, after that, I've been able to make changes to either my core sleep routine and habits or how I work at night or both that I think has been useful to me in terms of being able to do those things better. So just doing that teaching can begin to make a difference when we're thinking about how to manage this better. That teaching, by the way, is summarized in this paper. So it's intended to be a 15-minute read. And it just kind of summarizes many of the key concepts around about sleep for your own health when you are working shifts in particular, although there's quite a lot of general sleep advice in there as well. So if you want, I can share this link at the end with Aishan to distribute, but that will take you to that paper. There are other things out there that can help with that. So the last year, Sleepio has been available for free to everybody within the NHS. Sleepio is an online cognitive behavioral therapy tool that helps people to assess and improve their own sleep. And actually for adults with any kind of sleep difficulty or who want to improve their sleep, Sleepio has very proven to be able to make a difference. The problem with Sleepio for you guys is that it is intended really for people who are able to be awake in the daytime and asleep at nighttime. It's a bit more difficult to follow Sleepio's recommendations if you're also working shifts. But if you're not working shifts or if you only have to work shifts less often than once every 6 weeks, Sleepio can be a really good way to help you look at your current sleep pattern and tune it up and optimize it as much as possible. We then start to move away from the individual aspects of this, though, and start to think about the systemic aspects. And I think these are the more important bits. In the NHS as it stands at present, and this was true before COVID came along, there's a huge problem in that many NHS staff are feeling the consequences of trying to deliver a service where the resources in the system do not match the demand on it. And what that often means is that we often fill those gaps with our own reserves. We fill in the space, what's missing, by over giving from ourselves to try and maintain things as best as we can. The problem with that is that nobody is able to carry on doing that indefinitely. And what that then leads to is a huge problem within the NHS as a whole that is manifest in many ways. But one of those is this concept of burnout, the idea that there are many, many people in the NHS, and this is pre-COVID, where they are just functioning well beyond their safety line, if you like. And for many of them, that then means they end up burning out, having to take time away. Some of them even leave the profession altogether as a consequence. Pre-COVID, we were beginning to assess the incidence of burnout again through the GMC survey. So those of you who filled in the GMC survey will know that for the last few years, there have been questions included that ask about burnout or are trying to assess burnout. And again, when we look across specialties and at all grades, what it tells us is about 25% of people who fill in the survey are already ringing up saying that they are at high risk of burnout. So again, this is a huge problem for the NHS as a whole, and it's one I think that we've kind of surfed through the last year. The next year, I think, after we've had a year that we've just had where people have so much given beyond their normal in many cases, where I think we'll now see the kickback from that as people have become exhausted, and I think we'll see big problems in terms of further loss to the profession as a consequence of that. The word that often comes hot on the heels of burnout is resilience, and it's a word that people often have very strong feelings about. Resilience at its worst, people kind of are often thrown resilience as a, well, you just need to be able to cope better and that will solve the problem. And that is clearly nonsense. And you do not treat a systemic problem by telling people that they have to cope better. You know, that kind of idea of feel free to cope, that is the kind of the old-fashioned stereotype that many of us may remember. Well, hopefully you don't, you're much younger than me, I suspect, but I certainly remember from the early days of my training. The problem with that, though, is that people today often then look at resilience as a very negative thing, and it's kind of very much framed as, well, this is not the solution. You know, resilience teaching, resilience training is not going to solve my problems when I'm thinking about the fact that I'm working without the resources I need, or we're working in very stretched NHS in general. But the difficulty is that there is still a lot of value in resilience concepts. And actually, me spending an hour talking to anyone about sleep and sleep deprivation and trying to think about how to optimize individuals' own sleep is effectively a form of resilience teaching. I very rarely correlate that because it just upsets people. But the most important part about resilience as a concept is it can only ever be part of the solution. And whilst I think there are things that we can do to improve people's individual resilience in coping with these kind of things, it's not natural to work at 3 o'clock in the morning. So teaching you how to do that better is absolutely something that I think is worth doing. But it can only ever be part of the solution. And any kind of approach to these things has to also tie in the systemic responsibility of this as well. What that often means is trying to think about things that change the culture about the way the NHS works. And changing culture in the NHS is very challenging. So changing culture in the NHS often feels a bit like this. You know, you kind of pop along with your fancy new round wheels, and the NHS says, nah, we're quite happy working with our square wheels. They've done us fine. We're not changing. So even when we think making changes is actually going to make things better, getting people to actually acknowledge that and change their mindset, the way they think about things, can be really difficult. And one of the really obvious examples of that touches on one of those things I mentioned briefly a few minutes ago, which is that from a sleep circadian perspective, when people are working around the clock, taking short power naps at night, we're talking about 15 to 20-minute periods of sleep at night, which will fit into a break, is actually something that many people will find is effective to them in managing their fatigue. And industries like the airline industry, for example, pilots on long-haul flights have access to beds to be able to go and take power naps during long-haul flights because it helps them to keep functioning. But in hospital environments, what we often find is that sleep is very much actively discouraged, and that certainly historically there would be this attitude of if you're caught sleeping on a night shift, you're going to be disciplined and punished. And that is then a useful focus. So when I was originally doing work around our deanery about how to look at how much of a problem we had, one of the questions we asked was, does your department support power naps at night? And if the department said no, which the vast majority did when we first started doing this work, that tells me that department doesn't understand circadian physiology and the impact of shift work at all. And it then gives us something that we can hang a hat on to be able to write, this is why this is wrong, and this is why you need to change it. I did a lot of work with paediatric centres around London in 2016, 2017. And over the space of a year, we improved the response rate of that from 15% up to 48%. I think it's a lot higher than that now. I've not been back to resurvey it. But changing attitudes takes a lot of work, and it takes a lot of persistence to really get people to change the way that we've done things and have done them for a very long time. One of the other things that is similar to that is the attitude to rest and breaks. And in the NHS, we have very much normalized the experience often that if you have a long shift and you get a break, it's like, oh, that's great, I got a bonus break. But we've stopped thinking about breaks as being something that we necessarily expect to get in quite a lot of circumstances. And that undermines the kind of concept of what a break is intended for. If you think back to that performance curve, if you think back to that increased risk of a mistake or an accident happening when you go from 8 hours to 12 hours, that doubling of risk, all of that is modulated by rest and breaks. If you do not get regular rest and breaks, particularly if you're working long shifts, then actually your ability to sustain your performance at the top of your performance curve is impaired. There's no way that you are going to be able to sustain your best performance for a full 12 to 13 hour stretch if you don't stop and take regular rest and breaks. But we don't tend to think about breaks in the NHS like that. We should think about breaks as being absolutely integral to the care that we deliver. But instead, we tend to think of them as a luxury, as a bonus. So we've done a lot of work. So within Guy's and St Thomas's over the last few years, we've tried to do a lot of work about trying to change the way that we think about rest and breaks to really get across the emphasis that breaks are meant to be an essential part of delivering the best quality care to our patients. And if staff are not getting breaks, we cannot deliver the best quality care. So thinking about attitudes to rest and breaks is really important. That also, however, ties in with this idea that within the NHS, we often give people the impression that somehow they are better able to cope than other people. On some level, we tell people or reinforce subliminally the idea that people are superhuman, that NHS doctors and nurses are able to go longer without breaks, and that's you're just expected to be able to do it. We used to give out at Guy's and St Thomas's, we used to give to our nursing staff a free tote bag that said, what's your superpower? Mine's I'm a GSTT nurse. And people loved it. It was like a validation of how brilliant they were. And they're absolutely brilliant, as many of us will know. But if you flip that sentiment the other way around, if you are not superhuman, you are not good enough to work at our trust. And as soon as you put it that way around, you can see just how toxic and corrosive these kind of ideas are. But this kind of idea that we hold NHS staff to an impossible standard is one that is really pervasive. So again, we have to really emphasize that you are just as boringly human as everybody else, and your ability to function, to sustain performance is no better than the average person's in terms of doing this. At an organizational level, there are things that are being put in place to try and help with that. So the much loved junior doctors contract negotiations from a few years ago, lots of controversy around that, as you will all well know. But from a fatigue perspective, actually the junior doctor contract had some really positive things in it. For the first time, the junior doctor contract made clear the fact that when you do not get your rest and breaks as the contract states you should do, you are not providing safe patient care. Breaks are necessary to ensure patient safety. And that is the exact emphasis that we should be putting on this. I still think we're very bad at reminding ourselves of that. We feel guilty when we stop and take a break, when it means that someone's going to have to wait a bit longer. As long as they're not having a cardiac arrest and they don't need immediate care, actually, you're probably going to give them better care if you stop and take a break, than if you just carry on regardless. We've done a lot of work, so as I already mentioned, we've done a lot of work with the anaesthetic colleges, and they produce a lot of resources around this type of work to try and support that. We've worked with colleges like the Emergency Medicine College about putting things in. They quite like that "you are not a superhero" idea, so they use that as the focus for their piece of work around this. And we've worked with the BMA, and that's produced the Fatigue and Facilities Charter, which puts in place recommendations about what hospitals should be doing around about this. So there are lots of very practical recommendations, pardon me, in amongst all of this that hospitals can and should be doing to try and support this work better. A lot of it, though, does boil back to very simple basics. When I was a medical student, one of the very first things I was told to read was this book, The House of God, which is quite old now, so it was written at the end of the 70s. And it describes the experience of medical interns in the US in the 70s. So it's a little bit of a foreign environment compared to the NHS, but there's a lot of universality about the experience of being a junior doctor, regardless of the location and the time. And lots of it still rings very true with doctors who read it today. There's one character in that, though, that has this to say, and he says, "How can we care for patients if nobody cares for us?" And that, as a fundamental concept, is something that is often missing, I think, when we think about how we deliver care in the NHS. More recently, we have started to be better about this, and there's been an awful lot more thought given to well-being of NHS staff in general, so even before the pandemic, and how important looking after our staff is to the care that we are here to deliver. This is a report that Health Education England published a couple of years ago now, looking at the mental health and well-being of NHS staff. And it asks exactly the same question that the House of God was asking at the end of the 70s. Who cares for the people? Who cares for the nation's health? And if we don't get this right, if we don't look after our staff, then actually we're not able to deliver care to our patients as best as we should do. At the end of 2019, the GMC had commissioned a survey that looked at the similar kind of issues, looking at doctors in particular. And that report, Caring for Doctors, Caring for Patients, was a really comprehensive overview of all of the elements that are looking at what impacts on the care that we deliver. Michael West, who was one of the co-authors of the report, had this to say: "We can't simply go on the way we are, loading more responsibility onto doctors already struggling to cope. Where workloads are excessive, patient care suffers." Mm-hmm. And what that's beginning to get at is this tension that is there in the NHS, that for so long we have normalized delivering care without the adequate resources to deliver it. And we now think that that's what we should be doing. But we cannot carry on like this. We will continue to see people burning out and leaving the profession, and things becoming progressively more difficult if we don't stop and think about how we care for our staff. Michael and Denise's report emphasise a number of things that are key to that, but actually they emphasise the absolutely fundamental importance of thinking about rest, sleep deprivation and fatigue in how we deliver care, and also about the kind of things like making sure that when we design rota patterns that they make sense in terms of body clock physiology. At the beginning of 2020, with these just having been published in 2019, this came out just at the end of 2019, I was in a fairly optimistic place about this body of work as a whole. So something that had started about trying to support doctors working night shifts, that had become about fatigue, that had then become about staff well-being in general, was in a very good place at the end of 2019 in terms of the weight of resources that we then had emphasising the importance of all these points. And then obviously coronavirus came along and kind of blew everything out of the water for a year and longer. The pandemic, though, has really emphasised the importance of these points. And actually, at the beginning of the pandemic, myself and Srini Yadka, a psychologist colleague, and I wrote an article in the BMJ saying that if we were going to be thinking about the response to the pandemic, we absolutely had to be building in looking after staff into that. And I'm pleased that many trusts have done that really well. But we've absolutely emphasised the importance when dealing with the pandemic that looking after our staff has to be front and centre if we're going to be able to sustain the levels of performance that have been demanded from the NHS over the last year. The pandemic has also impacted sleep in lots of ways. So about 50% of every adult in the country has been sleeping less well, particularly during the first lockdown. And all of that was mediated through stress and anxiety and how that affects sleep quality. And that was particularly true for NHS staff who were really at the forefront of having to deal with all of this. So we produced some specific guidance about supporting sleep in the context of the pandemic, which I can send links to if people are interested. It also allowed us to do things that we've been talking about doing for a long time. So as part of the pandemic response at Guy's and St Thomas's, we finally managed to put in place sleep pods to support our staff to be able to have power naps at night. So those kind of basic principles. We've shifted from 10 years ago, a prevalent culture in the NHS that if you're caught sleeping on nights, you're going to be punished, to an organisation of the reputation, I guess, of Guy's and St Thomas's, not only turning that on its head, but actually investing money to provide facilities for staff to be able to have power naps on night shift. We're changing that culture. And then the other thing that the pandemic emphasized is the importance of using auxiliary things like headspace that help us to relax, to wind down, to think about getting good quality sleep. So I think over the last year, lots of people have found the benefit of things like this. One of the other things the pandemic also did was put people like me, and I suspect you guys as well, into unfamiliar circumstances. So I got redeployed to our adult ECMO intensive care unit for a few weeks last year. And what that meant, I was on a rotating rota, 3 on, 3 off, days, nights, 13-hour shifts, all the rest of it in a busy environment. That meant I was able to put into practice all these kind of principles that I've been talking about as part of the critical care team. And because I'm a sleep physician, I tracked it. And what I was able to demonstrate that me and I should be better than anybody about doing this. So even when I am following all of my own recommendations and trying to manage my sleep on a rotating night shift pattern as best as I possibly can, I was able to demonstrate that actually my sleep was still very significantly negatively impacted. And the cumulative impact of fatigue when working 3 days on, 3 days off, 3 nights on, 3 nights off was very clearly able to be demonstrated in doing that. And what that really emphasizes is that there is no way that any individual is ever going to be able to cope with working around the clock. It has to be a systemic approach to how we support people. The other thing the pandemic also threw up was quite a lot of reinforcement of this idea that NHS staff are brilliant and superhuman. And yes, we are. And yes, lots of people did amazing things last year. But again, it meant that those of us who then felt we weren't able to constantly give 150% felt like we were failing our colleagues. So again, there's this kind of toxic, corrosive quality about this kind of idea that NHS staff are superhuman that we have to tackle. So what do we still have to do? There is still a lot of work to be done. There are huge concepts here. This goes to the heart of how we deliver care, and it's a very difficult problem to tackle. We continue to work with all the professional organizations, so all the various colleges and all the rest of it. One key thing that I think is absolutely essential is that we need to build teaching about this as basics into everybody's induction so that people are getting the kind of teaching that gives people the skills to be able to manage their own sleep better right from the beginning of their careers to try and be able to manage working shift patterns and around the clock better. We continue to challenge trusts and organizations to think about what their attitude to rest and breaks is. And this is absolutely fundamental. If you've got a culture where people who work without breaks are kind of tacitly rewarded or praised for coping and all the rest of it, and actually you're just perpetuating the problem. So we need to really challenge the culture around rest and breaks. And we need to get back to the point where rest and breaks are not seen as a luxury, but as an integral part of patient care. And there is also a role for thinking about how we use things like Headspace and Sleepio to support our staff. That needs to tie into ongoing work, which the pandemic has very much emphasized, about the importance of staff well-being. There is likely to be a role over time for things like fatigue management systems, although there are a lot of problems with these within the context of the NHS at the moment, so I don't think they're quite ready to be used within the NHS, but the technology exists. We can objectively measure fatigue in staff and think about that. But fundamentally, the thing that really affects all of this is safe staffing. And we have normalized a standard of care in the NHS over the last decade in particular, where the care that we are delivering is very much being delivered with far less than the resources that we all know are needed. And until we get genuinely safe levels of staffing, it's really difficult to make meaningful further changes in a lot of this. Left. That is me. It's kind of a kind of overview of all of those kind of concepts. If you want links to some of the things that I've talked about, that kind of summarizes the links. I'll leave that up for a few seconds.
There was a question about whether you've had any experience with catalepsy and microsleep.
Yeah, absolutely. So cataplexy is quite a specific symptom. So cataplexy is a symptom of narcolepsy, but so that's probably less relevant unless I've misinterpreted the question. Microsleeps, though, are very much part of this problem. And so a microsleep is where you literally fall asleep for a few seconds. And that can have, so most of the time that doesn't have a big impact. Microsleeps, though, are almost certainly one of the mechanisms by which people crash and die behind the wheel of a car. If you have a microsleep whilst walking home from work, then you're probably going to be fine. If you have a microsleep doing 60 miles an hour in the third lane of the motorway driving home, then even falling asleep for a second or two may be the difference between life and death. That also has relevance in a surgical environment. So there is data looking at microsleeps and fatigue in operating theatres. And obviously, when you are trying to focus on intricate operations, a lot of this is the research is done around things like neurosurgery, but I think it applies across the board, where even that momentary lapse of concentration, if you are falling asleep for just a few seconds, can make a big difference in terms of what you're doing. So yeah, microsleeps are very definitely a part of this, but the solution is improving all of these principles across the board.
Great. I mean, just to tie into that, have you done any work with the Royal College of Surgeons at all on sleep and the effects with surgeons? I mean,
surgeons historically are the specialty who are most resistant to thinking about these issues. The Fight Fatigue campaign, which the anaesthetists spearheaded, the surgeons, I think, were one of the last colleges to sign up to that, and it took a bit of persuasion. So I have done a bit of work with surgeons. I've talked at a few surgical conferences. I've had conversations with people in the colleges, but there is that kind of attitude of, to train a surgeon, you have to train in the way that we trained, is quite prevalent. And I think, and you're more experts in this than I am, I think in the olden days, the people who didn't cope just left the profession, where so that the people who got to be consultants under the old school training were by definition the people who had survived kind of doing training the old school way. I don't really think that's the way we should be training anymore, but there's still quite a lot of resistance to changing. I had an article in the BMJ a few years ago arguing with a professor of surgery in the States, because he was arguing that it was bad for junior doctors to work less than 28-hour shifts, because if they were being namby-pamby and only working 12 hours, then the continuity of care for the patient was very much affected and they wouldn't get the same training experience. So I was very much saying, well, I really don't think that's true. But anyway, so yes, but it is probably the specialty with the most average resistance. There are very definitely people who get it and are very keen to engage, but yeah, it's more challenging in surgery than the other specialties.
And sort of tying into that, I mean, a lot of us at registrar level, we do second on calls overnight, and our sleep tends to be fairly broken sleep because we tend to get a lot of calls overnight. From point of view of the effect that that would have on someone's performance the next day when they're expected to
absolutely
performing.
So the anaesthetists, when they started doing their work, were very much focused on trainees, but they've now moved on to look at consultants, and that begins to pull in a lot more about on-call sleep. Again, there is data for this as well. If you are on call, even if you do not get called at all, on average, people who are on call sleep less well than people who are not on call, because on one level, your brain is permanently kind of, you don't, oh my God, what have I fallen asleep? What have I missed it? And all that. So you just don't get into good quality sleep. So that means even if you don't get called, you are likely to be more sleep deprived the next morning than if you'd had a normal night's sleep. And that's why, so anaesthetists in general tend to be a lot better about this, but anaesthetic rotas for consultants, if they've been on call overnight, second on call, they will often make sure that they're not scheduled for an operating list the next day, so that if they're it doesn't impact. So yes, there absolutely is an impact, and it is something we should think about. And obviously, if you have been called on top of that, then that impacts it even more. And yeah, if you then have a full day of operating the next day, then you're not going to be at your best. And most of the time, you're probably going to be fine. It's like, so this is the problem is, so if you have 3 pints of beer and get behind the wheel of a car, you're not going to die. Most of the time, you're not going to die. Most of the time, you're going to be fine. But your risk of an accident or making a mistake goes up. And one of the reasons that I'm not keen on fatigue management systems in the NHS at the moment is, at the moment, if you then made a mistake in your operation because you were fatigued, the only person that's going to be held responsible for that is you. Whereas I think that should be a systemic responsibility rather than an individual one. And we need to get that right before we think about this in the NHS. So yes is the short answer.
Okay. And there's a question in the chat about, is there half brain sleep? And talking about Napoleon, question mark, question mark, question mark.
So yes, but not in humans. So dolphins and birds, they tend to sleep with half of their brain at a time, because so for birds that do that, it allows them to fly whilst they're asleep. So they literally, half of their brain goes to sleep and the other half remains awake, and then it flips over after a while. Dolphins do something similar when they sleep, because they if they are fully asleep, because they're mammals, if they stop moving, they stop being able to breathe underwater. So they only sleep with half their brains. But yeah, humans don't do that. Napoleon was one of many famous people who gives the impression that sleep is for the weak. And actually, I should dig out that BMJ article, because that's one of the points that I made in that, was this kind of idea that there's often a culture, this kind of concept that people who need sleep are somehow weak and not up to the task. And Napoleon was one of the people that perpetuated that, as is Boris Johnson, as was Donald Trump, as was Margaret Thatcher, as was Ronald Reagan. And I would argue that all of these people went on in both their immediate and then later lives to show some of the impacts of sleep deprivation.
And one last question that's there is that, is there any relationship between shift work and cancer?
Yes, we think so. So particularly for some types of cancer, it does look like there is an increased risk of developing those if you're a long-term shift worker. And it's one of the areas that there is ongoing research to really tease that out. But if you look at the incidence of breast cancer in women who work permanent nights, there are differences. So yes. Anytime we are working against our body clocks, there are costs. There's a circadian clock in every cell of your body. And when you are constantly fighting against that, there are consequences and costs. And one of those is an increased risk of some types of cancer.
And thanks a lot, Mike. I really appreciate it. I think especially as surgeons, we tend to take things in our stride way more than we should, and probably be talking more about fatigue and how to reduce that amongst trainees and consultants. I mean, we've got a fairly high burnout rate as it is.